with older adults with orthopedic conditions. Morten.
Okay, thank you. And I would like to thank the organization for this invitation. And it's right, I was given the task to talk on rapid and intensive rehabilitation. Is it possible? And as you can see, I added a little and effective. So I will also try to touch on that. So, I have no conflicts of interest. And since I'm a physio, I thought I would take the physical exercise aspect. I know rehabilitation is much broader and covers many things. So this will be focused on physical exercise studies. And we have this American guideline, clinical practice guideline, that says there's a strong recommendation for progressive high-intensity strength, balance, weight-bearing, and functional mobility training across the entire episode of care. So, but what about the very short term? Can it be done rapid, intensive, and short early after hip fracture? And that will be the focus. Hip fracture is my main topic. And the studies I will use as background, it's some register studies, and it's some RCTs that were pre-registered and that also reported on adherence to program and published more or less within the last 10 years. So, and this is from a famous movie series, Fast and Furious. So this is not what we think of when talking about hip fracture patients, but maybe we can speed things up. The first thing, and this is common knowledge for you, early mobilizations, it's so central, and we have from 3 national registries that in different ways show that this early mobilization is really important, and patients not able to be mobilized, they're doing worse, they're not getting back to their own home, they're staying longer in hospital, and from the last one, Irish, it was also in the Danish, there's a much higher mortality within 30 days or within hospital. So we don't need to question that. They need to get out of bed as soon as possible after having surgery. We also saw in the Danish registry on 2 studies that recovering the mobility at time of hospital discharge. And in Denmark, this is a bit more than 1 week. It used to be longer, but it's going down as everywhere else. So, and we saw those patients that did not recover the basic mobility level they had before they fractured their hip, they experienced a 2.8 higher risk of 30-day mortality and a 26% increased risk for 30-day readmission. And this was in a 1-year cohort from the National Register of more than 5,000 patients. In a later study, we was specifically looking at any infection and was based on prescription of antibiotics from another national register. And we saw that those that did not recover mobility experienced an increased risk of 35% for any infection and the same for pneumonia. So this seems, it's not only the first day, it also seems to matter how they are doing about 1 week after surgery and when leaving the acute hospital. So what can be done about it? And there are many Australians here, there's just one on the podium, and they actually do some very nice studies, or did some very nice studies looking into this. So this group was in the acute setting, and both groups had the regular physiotherapy, which is about 30 minutes in that setting, and that was the morning session. And then the intervention group had 2 extra sessions, and it was 7 days a week. So that's one of the most intensive studies I've seen on extra physiotherapy, 1.5 hours a day, and was progressed on these limb exercises, gait retraining, and focused on independence. So primary outcome was already on day 5, and that was a bit surprised to me, that because that's very early. They almost didn't have the entire intervention, but still that was it, what was chosen. But they had several secondary outcomes, and I will come back to some of them. So primary outcome on day 5, there were no difference between the two groups in the primary analysis, but there was small differences favoring the intervention in the intensive group on this 5-day outcome. But on secondary outcomes that also included the entire length of stay, that was in the acute and in the rehab, there was a significant difference in total length of stay favoring the intervention group. And but to me, actually, the most important outcome was this physical readiness for discharge. And that was focused on independence in bed, chair, and walking, and also negotiating stairs if that was necessary for returning to their own home. And if we see how much physiotherapy was actually given, you have the physio occasions. There was a plus of median of 5.5 sessions, and but in hours there was a plus of 133 hours extra physiotherapy for the entire group in the intervention compared to the control. So this is quite a lot. They didn't report on adherence to programs, so we don't really know if some of the sessions were missed for some reasons, but still it was much more physiotherapy in the acute setting. And there you have time to physical readiness. It was about 11 days earlier the intervention group reached that level compared to the control group. And also you see length of stay was also markedly shorter. One could wonder how come they reached this physical readiness 16 days, they stayed in the hospital 1 more week. How come they were in the rehab hospital 1 more week? But that's another topic or talk. They also looked at where did they go, these patients, and there were actually a tendency in being discharged to own home from the acute setting. But in total, final discharge destination, there were no difference between the groups. So I think we can say rapid, high-intensity physiotherapy, it seems possible and effective in speeding up time to physical readiness for discharge and also reducing total length of stay after hip fracture. So, and I think this study, they refer to the previous, and they were little less ambitious, but it was the same approach. Does 3 times a day give a better outcome than the more usual 1 time a day? But in this study, the time was the same. It wasn't extra time. So they had 45 minutes, and then they had 3.15 minutes over the usual working day, as I read it. So, and this didn't include the weekends. So this is something that more easily maybe could be applied to a regular program. So same training in both groups. They follow this exercise program that also included the Otago exercise program. And they didn't find any difference on the primary outcome at 2 weeks or at discharge, nor on any secondary outcomes. And they also find that adherence was a bit worse in the intervention group compared to the regular group with only 1 session. Main reason for missed sessions was refusal. They didn't want all that physiotherapy that must have been compromised during normal working hours. Or it could also be the participant or the physio were unavailable, or the participant was asleep. offering physio using the same time in 3 versus 1 session a day seems to reduce adherence a little, and actually with no effect on outcome. Then there's some study from the UK, hip sprint audit from Katie Sheehan's group, and they were focused on, does it matter how much physiotherapy you get in the first week after having a hip fracture? And the outcomes were discharge home, readmission, survival, and recovery at a bit longer term. And this is put it into a table. The percentages is the adjusted probability of a positive outcome for those that had 2 or more hours versus less in the first column. In the next column, it was those that both had mobilization and exercise during the first week. And in the last column, it was those that had physiotherapy 6 to 7 days a week versus 0 to 2 days. So altogether, it suggests that first week, greater access to physiotherapy was associated with a higher probability of a positive outcome. Similar study from Japan that also came out this year looked at additional rehab 6 to 7 days versus weekdays only, and they saw a reduced in-hospital mortality of 14% and fewer complications. And that altogether seems like this higher dose, or take the first one, early mobilization, greater mobility at time of acute hospital discharge is associated with better outcomes, and also a higher dose of acute physiotherapy and on more days seems possible and associated with better outcomes. And then those that had the combination of mobilization and exercise seems to do better on some outcomes, but not on mortality. And the other focus I will have is on strength training. Is it possible very early? And first, one could ask, is it at all relevant for these patients? So this is data extracted from 4 different studies. And what we saw was, and you can see, there's a reduction of muscle strength in the fractured leg compared to the non-fractured of about 50%, no matter if it's muscle power or muscle strength that is being evaluated. And so they experience an immediate drop of muscle strength. In another study, this is some of my own also, we combined data from 3 studies. And we were interested in this knee extension strength of the non-fractured leg. Does this say something about their mortality on the long term? And we used some cut points that was defined for elderly people, and we applied them to this data set. And be aware that patients that went into these 3 studies, they were some of the very best patients with hip fracture, the highest functioning patients. And what we saw was that about 50% of them, they had signs of sarcopenia related to strength of the non-fractured leg, the so-called healthy leg. And as you can see, mortality for those with signs of sarcopenia was about 22% compared to almost survival of all those not having signs of sarcopenia, just related to the quadricep strength of the healthy leg. So it seems to matter. So can we practice strength training very early after hip fracture? And we looked into that in a feasibility study. Patients had the daily physiotherapy, first 3 days, no matter what day, also during weekends, and thereafter most often 1 day on weekdays. And then they had one extra strength training session daily on weekdays during normal working hours, and it was started about 2 days after surgery, and it was the same physio providing the strength training. And she's on the picture. Some of you will know her, it's Lise Kronborg. The training was focused on 10 repetition maximum, but patients were instructed to continue to failure in each set. And if they could do more than 12 repetitions, we put on extra load on a set-to-set basis. If it was below 8, we took on some weight. So this is important. You need to load them, and that was what we were aiming at. We had these very simple, low-budget weight cuffs from 0.5 to 10 kilo that were used for the study. So how did it go? They didn't get that many sessions because they were out of the hospital within about 1 week. So on average, there were 4.3 strength training sessions for this group. And you can see the first session, it's not a lot of load. It was about 1.5 kilo on the fractured leg, knee extension, isolated. But the progression over very few sessions was quite nice if you look at the percentage increase in weight loads. And what was our primary focus was to see, is this possible? And this was monitored very carefully together with pain, and we saw that 86% of all sessions were completed as planned. And there were actually only 3 sessions that were not completed due to pain. So this was quite promising, and there were quite a lot of skepticism about this. Everyone said, you cannot do this, they will experience too much pain, but didn't go that way. So the next thing we thought, we also looked at this huge strength deficit that we saw in the other studies. Could we also do something about that? So they had their knee extension isometric measured before we started and after finishing, before leaving the hospital. And this group also started with a level of 50% of the non-fractured leg, but after these few sessions, there was a positive 18% reduction of the strength deficit. So this was extra promising. So we went for an RCT to find out, we know it's possible. We wanted to find out, is this also effective? So this was a randomized trial with 90 patients, followed the same program as in the feasibility study. But since results were so positive, we thought, well, why not go all in and do it every day, also during the weekends? So we had many different physios in on weekends, and also this was the physios on the ward doing the training, both the regular session and also the strength session. So that was a difference compared, and then the extra 2 days. Otherwise, same program. And they got a few more sessions, so now an average of 5.5 sessions. And primary outcome was the strength in percent of the non-fractured. We wanted to reduce this deficit. And it wasn't a significant difference, but it was close to about 8% improvement in favor of additional strength training versus control. And I think considering very few sessions in a acute setting, this is pretty nice. There were also differences. There were more loading was higher in this, so the physios were giving it more attention, so it started higher and it also ended higher. And compliance wasn't as good. There were but still 80% of all planned sessions were completed. Main reasons for not completing were pain and fatigue. So maybe 7 days of training, maybe it also influenced their strength performance when we tested them, because it seems too much. Maybe it was too much. So the good message is it's possible. You can start already few days after surgery to load these muscles in a progressed way. I think there's a tendency in it that it does improve. And I think just loading these muscles is very important, also related to their functional performance. We know there's a strong association, and strength training is the recommendation across the entire continuum of rehabilitation. So, and I'm running out of time, so this is good. This is my last slide. So, but still, if you need to prioritize when you are in the acute setting, I would say go for the mobility first. Get patients back to an independent mobility status so they at least can move around at the ward or in their own home. We know they will be more physically active then. They use that opportunity actually. And then use specific exercises targeting what's needed to get to that point. And thereafter, progressive strength training is a must. And of course, if you have time and resources, combine it from start of your rehabilitation and already in the acute setting. And, but still, we need studies that start early, intensive, and continue the program across the different settings. So, so there's opportunities for more research here. Thank you.
Thank you. Thank you, Morten. Before, let's see, any questions? We have time for 1 or 2 questions before we adjourn. Morten, I have a question. Any thoughts? I think it, was there a question?
Yes.
You have to go to the microphone for a question. But I'll ask it while you have a question?
Yes.
Go ahead. Well, I'll ask my question real quickly.
Yeah.
Which is, how would you, I think we've actually heard from Jack talking about nutrition. So if you can put the two together,
Yeah.
You think we'd see more benefit, or you think we don't know? Maybe we do know. Have there been studies doing anything
I think
that
it,
intensive, that early, together with nutrition? Either of you?
Yeah. I certainly think that would be an important combination. And we did another study, but that was outpatient, where we actually combined strength training, nutritional supplements, and also anabolic steroids. But that's another talk. So sure, they were in the hospital, but we didn't take. It wasn't part of the intervention. But there was a focus on giving them these nutritional supplements. But if they took them, we didn't monitor. So, good point.
And the
Yes,
final
hi.
question of the
Yeah.
afternoon.
I'm Maria Panurgia, a geriatrician from UK. I wanted to ask, it is a question with 2 parts, if that's possible. The first is, when you were doing the weight strength exercises, were you using it in both limbs? I suppose yes?
Yeah.
They were both legs.
Yeah. We actually only trained the fractured leg,
Okay.
because we were interested in reducing this huge strength deficit. But I think it makes perfectly sense to offer strength training also for the non-fractured leg, because as we could see, and those in the study that I referred to with the 1-year mortality, this was some of our very best patients included in studies. So if we look at the entire population of hip fracture patients, well, I guess 75–80% will be sarcopenic, or at least have signs of sarcopenia related to strength in the lower limb. So, yeah.
And the second is, more of your opinion rather than to answer. It is an opinion from your side. Would it be possible, is it necessary to be a physiotherapist that applies the weight? Couldn't be a nurse? And could they be together more patients having the weight and move their limbs while somebody in the same bay watches them doing the right thing instead of having one-to-one? Because the majority of the problem we have, it is that we don't have enough physios. So I cannot, it's an amazing thing to do it, but I cannot see it happening if we don't have the resources. So if it is one person that can follow like an exercise class in the gym, what do you think? Could it happen?
So, really here, difficult to get. Could you make the question short?
Yes.
Yes.
If there is one physiotherapist seeing more people in the same room doing the exercise, could this happen?
I think so. It's a good point, and I think we did it after more classic strength training principles, and that's of course the best. But I think just loading these muscles in some way, applying some kind of weight, will be better than nothing, and that could actually be done in the groups. Yeah, so it's a good point. That would work fine, and they actually liked it, patients, because they said, well, they could feel it was hard, and you need to prepare them that they will experience muscle soreness. But we said to them, well, that's actually a good sign. It shows you did the exercises as we wanted you to do. So they will experience, some of them, they have never practiced strength training, of course. It's not that common in that elderly population. So, yeah, thanks.
Thank you.
Then all three speakers on the floor, please. You will receive your well